Hello, this is Devnath Chatterjee from the Children's Hospital of Colorado and the University of Colorado. I'm a member of the editorial board at openanesthesia.org. You are listening to the March 2017 Article of the Month podcast, a special online feature of anesthesia and analgesia and openanesthesia.org. Our article this month is an editorial titled Be Focused, the Time is Now, that appears in the March 2017 issue of Anesthesia and Analgesia. This editorial accompanies two other articles, including a narrative review article on why anesthesiologists must incorporate focused cardiac ultrasound into daily practice and an illustrative guide on the nuts and bolts of performing a focused cardiovascular ultrasound for perioperative hemodynamic assessment. I would like to extend a warm welcome to the first author of this editorial, Dr. Nick Skubas, who is a professor of anesthesiology and cardiothoracic surgery and the chief of cardiac anesthesia at Weill Medical College, Cornell University in New York. Thank you, Dr. Skubas, for joining me.
Good morning, Dave, and thank you very much for the kind invitation, and good morning to all the readers and listeners.
Great. Can you start off by telling us about your interest in this topic?
The applications of ultrasound have always been a fascinating issue. I started with transesophageal echocardiography, and over the course of almost 20 years in my career, I realized that we are using ultrasound more and more, from placement of central venous lines to using point-of-care ultrasound in the intensive care unit, in the emergency department. I realized that ultrasound has a great potential, and with these two articles and this issue of anesthesia and analgesia, we realized that it can be a really great tool in our armamentarium to take care of our patients.
Thank you. So can you briefly describe the essential features of a focus exam? So what would be the common indications to perform a focus examination?
So focus is an transthoracic ultrasound, which is brief, very short, very quick to do. It is based only on the acquisition of 5 views only, and it is very limited in its diagnostic scope. It can be done very quickly. The findings are qualitative in nature, and it can be done at any place by the treating physician, from the office to the operating room to the intensive care unit. The most common indications are any type of cardiovascular instability that may be associated with causes that can be treated, and this is where focus, the point-of-care ultrasound, can come into play. New symptoms of the patient in the pre-admission testing area, a high-risk cardiac patient who had not had any preoperative workup. Any questions about the physical status of the patient can be answered partially by performing a focus.
Now, the review article by Drs. Coker and Zimmerman describes the differences between focus and a limited transthoracic echocardiography exam. For the sake of our listeners, can you summarize the difference between the two?
So a limited transthoracic echocardiographic exam is traditionally done by trained echocardiographers, cardiologists, and it is done to address a wide spectrum of diagnosis. It requires an extensive fund of knowledge to be able to acquire views and make the potential diagnosis. While focus, because it is so narrow in its scope, basically addresses quickly the question how sick my patient may be, and because it is done at the point of care by anyone, is somehow, I should say, a very, very mini version of a limited transthoracic echo.
I also understand that unlike a limited transthoracic exam, the focus exam is not a separate billable activity. Can you please clarify that?
That is correct. There are no billing codes for focus. So you cannot and you should not devise any billing codes to bill for performing a focused echo exam. Limited TTE is, again, a small version of a full-blown transthoracic examination, and there are billing codes. There are no billing codes by the cardiologist. We, as anesthesiologists, do not bill, and we should not bill for this exam.
It was also interesting to read that a wide range of ultrasound equipment, from fully functional ultrasound platforms to handheld pocket-sized ultrasound devices, may be used for the focus exam. Can you comment on the recommended criteria for basic ultrasound equipment functionality to perform a focus exam?
So, focus is the exam, as you just alluded into, and this narrowed exam can be performed by any type of echocardiographic equipment. So it's not so much the equipment used, but the scope of the exam that describes this examination as a focused echocardiographic exam. The devices must have certain abilities for the focused exam to be performed accurately. That means that they need to have a transducer that is capable to interrogate shallow as well as deeper structures. There must be indications on the screen to identify how deep the structure is. The operator should be able to adjust the gain and the depth, that is, should be able to navigate the ultrasound beam at the desired organ, and the images and the movies should be stored digitally so that can be exported for quality assurances and perhaps even for placement in the patient's chart.
Now, as a limited qualitative exam that is meant to be used as an adjunct to clinical findings, what are some of the limitations of this ultrasound examination?
Well, there are basically two. Provided that your equipment is capable of performing this limited exam, the only other limitation is you or I, the operator. So it is very deeply affected by the experience of the user. The more inexperienced the user may be, the fewer the chances of getting or missing the information. The more experienced the user is, the easier the exam will be professionally accomplished and diagnosis done or avoided. So out of the two, I will probably emphasize again the operator. So the knowledge of the operator is the main limitation of the focus exam.
Thank you. You mentioned in your editorial that it is important to support the implementation of this innovative point-of-care ultrasound exam that you describe as lean, mean, and quick. Do you see any barriers to the routine adoption of this focused ultrasound examination?
Yes, certainly there are some barriers. First of all is that not perhaps many of the readers or listeners are aware of this type of exam, the focused ultrasound exam. People may be unfamiliar with the instruments, the devices that are used to perform focus. So they're usually handheld or pocket-sized devices. They may look like a smartphone or a small laptop, but perhaps the median or the half of the anesthesiologist practitioners, counting myself, we don't have the tactile dexterity to use this type of equipment. And I think, though, that the most significant barrier for adopting this is the fear of us as anesthesiologists sidestepping on somebody else's field. This shouldn't be so. We're more facile in recognizing transesophageal echocardiographic images, but more of us recognize transthoracic images. So we feel that we are trespassing perhaps the cardiologist field in trying to steal some of their practice or try to duplicate their work. But this shouldn't be the barrier that will stop us from performing focus.
Great. The current generation of anesthesiology trainees are taught how to use ultrasound for vascular access and regional blocks. In your opinion, should the focus examination also be included in their curriculum, and what is the best way to accomplish that?
I work in an academic place, but I believe that the majority of the anesthetics are done in non-academic places. However, trainees are coming out of academic places. I think the chairs, the ABA, all our societies, including the SCA, IRS, should come out strongly and boldly in support of this type of activities. And the biggest change required right now is to incorporate the teaching and training of handheld ultrasound devices into the curriculum of the anesthesiology training programs. So somehow this needs to be rearranged by recognizing the widespread appeal of ultrasound in general and make the ultrasound rotation, which has not need to be limited only in transesophageal echo, making a rotation of surface ultrasound almost an inherent part of every academic curriculum. And that goes along with allowing the mid-career trainers, teachers, they need to be educated as well. So not only our residents, but our staff need to welcome this technique by allowing them time and the means to train and practice.
In addition to the narrative review article and the illustrative guide in the March 2017 issue of Anesthesia and Analgesia, what additional resources are available for the practicing anesthesiologists?
Right now, all major national and international meetings offer courses in surface ultrasound, either at the annual ASA meeting, the IARS, the SCA, Critical Care Society meetings. All of them do offer workshops where the willing participant will get a little taste of this new technology. There are very many online courses, and the readers will find them once they read the two accompanying articles, such as FATE or the field protocols that are easily accessible online. And actually some of them do provide, such as the FATE protocol, free of charge applications for your smartphone so you can carry with you and read as you practice. So available resources are there. It's now time for us to use them.
Thank you, Dr. Skubas, for sharing your insights. I would encourage our listeners to read Dr. Skubas' editorial and the two accompanying articles on the focus exam by Drs. Coker and Zimmerman in the March 2017 issue of Anesthesia and Analgesia. Thank you again for joining us. Have a good day.
Thank you very much for having me. Have a good day as well.